This episode of The Benefit Whisperer is brought to you by Route 3 Insurance and Financial Services, where smarter benefits begin. If you're tired of rising healthcare costs and opaque insurance contracts, Route 3 is here to help you take control. They specialize in transparent, employer-driven benefit strategies that protect your people and your bottom line. Ready to break away from the status quo? Visit www.fixmybenefitsnow.com and discover how Route 3 can help you build a plan that actually works for your team and for your budget. Welcome to another episode of The Benefit Whisperer. I'm Ralph Weber, your host, and today we have a very, very special guest, somebody I've known for a very long time, somebody that I consider a friend, Libby Rosenthal. She was with New York Times for 22 years, an emergency room physician, KFF editor-in-chief for a while, senior contributor. And she has written a book, which I remember, Libby, you interviewed me for that years and years ago. That was called American Sickness. Yeah, that was the first time we met. And I still have two copies. I was going to bring one to work today. Because I still refer to it a lot. So welcome to the show, Libby. Glad to have you on.
Well, I'm glad to be here. I'm not so glad that the book is still relevant after all these years.
Well,
I was hoping the issues it raised would lead to more change than it has.
Yeah. No, I hear you. I did a recent sort of 6-episode miniseries on the history of healthcare in America, the last 100 years, starting in 1929 when the Baylor Dallas Teachers Plan formed the first prepaid health plan, which became Blue Cross. And interestingly enough, it was designed to solve one problem, and that was liquidity. Liquidity for patients and for hospitals, because during the Great Depression, nobody had work. People were being bankrupted by hospital bills. Hospitals were swimming in debt. And 100 years later,
here we are.
We're in the same boat. Yeah.
Yeah.
Except that it's
for entirely different reasons, of course.
Exactly. This time it's by design, because some of these people figured out that, hey, there is a lot of profit in opacity. Recently, I did some research, and the time that it takes to pay the hospital slowed down from 2024 to 2025 by 3.8 days. And that increased the profit of two of the big insurance companies, United Health and one of the Blue Cross groups, by $171 million a year, just that 3.8 day delay.
Sure. I joke that there are so many people who get these, $29 bills in the mail, and they're not sure if they're anything real or not.
Yeah.
But they just pay them, and they go, well, what's $29? Because it would take you more than $29 worth of your time to fight it. And people go, well, what's the difference? And, if you think of 100 million people each writing checks for $29 that they don't owe, it adds up to big bucks. So there's so many ways to game this system financially.
Yeah.
And none of them are really good for patients, because patients are kind of beside the point.
Yeah. And it's almost like the patient has become the product, where opacity is the business model and the patients are the profit center.
Yeah, someone said to me the other day, and I think this is true, that healthcare has become a kind of financial instrument.
Yeah. Yep.
And we just happen to be and our illnesses just happen to be the widgets they're getting passed through the transactions.
Exactly. And it's interesting because so many people say that the healthcare system, it's not logical. It doesn't make sense. If you think of it from a system that's supposed to provide healthcare, that's absolutely correct. It doesn't make sense. But if you think of it for what it's actually become is a money machine, then it actually does make sense. Create confusion, create opacity, create viscosity, slow down the flow of money. And when I had Mark Cuban on a couple of months ago, he talked about just holding on to that float and the amount of profit that created. And it really does. We were talking, Libby, just before the show about just that, what Mark is doing with direct contracting.
Yep.
He's got 40 facilities now at costpluswellness.com.
Right.
And I think that's definitely a huge I think there's a huge opportunity in direct contracting, removing all of, so many middlemen, the insurance companies and all these other people that get involved, and paying the hospital quicker.
Yeah. Yeah. I mean, that is absolutely true. The problem is really that, that now we have like an endless array of middlemen who are going to try and get in the way of that. And I think most companies don't have the knowledge to do direct contracting.
Right.
It's fraught with, it was same as with doctors who were doing DTC patient care. Okay, what happens when your patient needs something that you haven't thought of? Then they have to go. So it's the problem right now, and I think direct contracting is a partial answer for the companies and the hospitals that will agree to it, but some won't, because the hospitals have such power right now that. And they have political power, and, everyone is kind of fighting for their piece of the pie now. And how do you, the system as a financial instrument, when things don't make sense, the answer is, Epic or Cerner, the EMRs don't work well. A hospital buys one. Then there's this intermediary, like, stream of fish, one eating the other, to, EMR consultants to tell you how to use Epic. Like, nothing. There's so much friction. And I know Mark Cuban uses that word a lot. There's so much friction in the system. But how do you bypass that? It's really hard, because, I can rant about any part of the healthcare system.
Oh, yeah.
But, I think one big impediment is, the power hospitals have on the political scene and getting the prices they want, and making sure the power, it's like the land of the giants. These insurers have incredible power.
Yeah.
And, the employers are kind of these little guys. And I mean, remember a few years ago, you were around when this was happening too. What was it? 3 companies, big companies, JP Morgan Chase, and was it Google or Amazon and Berkshire Hathaway?
They
with,
all
with the Atul Gawande got together, and they tried to make it work for their employees. So there you're talking about, like, probably millions of employees dispersed across the nation, and they couldn't make it work. And I was like, yeah, this should work if you think of all the market power they have, but it didn't. So how do we kind of get a wedge into a system which is so powerful and also so hardwired in today's market? Like, I can see, and I've been watching Mark's experiment because I think it's really interesting. I mean, I think we can see, and I've heard of, in smaller communities, direct contracting with a hospital and some doctors groups. And that has worked pretty well. I mean, the Montana state employees plan, they did a direct contract for their employees with all the hospitals in the state, but, they were paying 245% of Medicare. I mean, that's still a lot. I was like, you save money that way? But yes, there's so much money sloshing around in the system. There are great opportunities with direct contracting. It's just that most HR departments aren't set up to do it. And I mean, I love the cost plus model because it's very transparent. What I worry about is there'll be all these new intermediaries in direct contracting, and we'll end up, with just more friction. But I like to say, it depends on the motivation of why you're creating the system. But I think the system makes the motivation, kind of,
Sure.
So, and we were talking before, employers have been kind of asleep at the wheel in this regard. And I think they're waking up to it because they can't afford insurance costs anymore for their employees.
Exactly. And, the RAND study, which is sort of the benchmark that's around 254%, it's sort of it's very much misinterpreted. Part of the study says that 254 is what hospitals are paid. But when you dig down really deep, that's not at all true. That's the allowable. Okay.
Yeah.
Because I asked Chris Whaley and Brian Briscombe just, a while ago, I said, let me understand this. So if let's say an allowable charge is $20,000, that represents 254. If it's split between the plan and the employee is responsible for 5,000, the plan for 15, that's 20,000 combined,
Right.
that's 254. Yes. Now, if the employee stiffs the plan completely, hospital gets 15,000. Is that 254? No, that's 75% of 254. So a lot of the research that I've done with Alex Chan, who's also a longtime friend, one of the things that I have found is that as deductibles increase, there's what I call the deductible curve. The higher the out-of-pocket responsibility for the patient, the less they pay and the longer it takes. Yeah. Balances that are over, $7,500, the hospital collects about, I think, 16% of the balance, and that is after, in some cases, 180 to 210 days. So what I'm getting to, Libby, is that the direct contracting has to have some component of quick pay and no employee responsibility. And if there is, it's behind the scenes. So if the employer pays the hospital all at once within, let's say, 1 to 4 weeks or whatever, and all of Mark Cuban's contracts are all 30 days.
Yeah.
I think that's where we can improve the efficiency.
Well, I hope so. It's a pretty new experiment, and I'm waiting to see how it works. I've become such a skeptic in the sense of, I'm looking at vertical consolidation now.
Yes.
In fact, the interview I'm doing after this is with someone at the FTC about that. So, hospitals, and on the insurer side, insurers, I was on a flight to Minneapolis recently, and I was sitting next to this kid, and I was like, "What do you do?" And he said, "I'm in private equity." And I'm like, explain to me what the game is when private equity is buying up doctors' practices. And he said, "Well, we sell them all to United Healthcare." So,
yeah.
That's happening on the insurer side. Meanwhile, hospitals are buying up physician practices. I guess the direct contracting, there's such asymmetric bargaining power. And that's something that employers have to deal with. I don't know of anyone who's doing something like Mark is doing, trying to do direct contracting for hospitals. I mean, he's done amazing things in the pharmaceutical sphere with cost plus drugs. But, the insurers say, yeah, sure, you can use cost plus drugs, but it's not going to count against your deductible. So, they're fighting back as hard as they can, as they will against direct contracting. I mean,
yeah, of course they will. Yeah, that and it's all to make more money, and when I talked to Kevin Schulman and David Schenker, David says that $1.7 trillion a year is just for moving money. That's how much we spend. Just the friction.
Yeah. No, I'm not surprised. I mean, and for that, we get lower lifespans in many other developed countries, higher infant mortality rates. We have a big and getting bigger chunk of people uninsured because of the loss of ACA subsidies, which, but the reason those are necessary is because the insurer rates are going up so much. So, how to break that cycle? I mean, insurers, yes, there's a ridiculous amount of profit generated by the friction, but we've allowed for-profit insurers. What do we expect them to do? Like, this is not Mother Teresa, selling you Cigna.
Right.
So I guess, their idea of success is not my idea of success or a company's idea of successful healthcare for their employees. Their idea is, I'm sorry to sound so skeptical about it, but, how can we deliver the cheapest care and earn the most money for our shareholders. Now, Germany has a lot of insurers, but they all have to be not for profit. And, I say that and then I think, well, yeah, all of, 2/3 of our hospitals are not for profit, but they don't act any different than the for-profit ones. So everything in our system acts according to its revenues and financial motives. And I used to put up like a Venn diagram of, this is what's good for healthcare. This is what's good for profit. And there's a little overlap.
Yeah.
Not a lot. And there should be, I'm not opposed to people making money. I'm not, but, the overlap should be substantial at least.
Right. Yes. No, I agree. And just before the show, we were talking about what Don Berwick said about, who has negotiating power in any negotiation? It's the purchaser, the buyer. But who is the buyer? Is it the patient? Is it the insurance company? It's really convoluted with any third-party payer system. But at the end of the day, who pays the most money other than Medicare, Medicaid, VA is the employer. Because 76% of Americans that are covered through private insurance are self-insured. So the employer is the biggest purchaser of healthcare. And what Don said is the employers are the dog that's not barking. Now, I remember in the American Sickness, you talked about that. You documented the patient side. So
and I said the employers are asleep at the wheel.
Yeah.
And they, it's partly that HR departments were never made to negotiate, with Cigna or United Healthcare. They're these little, 5-person things. They deal with people taking disability leave, and they hire a benefits consultant who gives them, it's like one from column B and one from column C. And, they're done for the year. But meanwhile, we all see that the premiums go up and there may be some cap, states say 10%. Well, great. If my rent went up 10% each year, you would be, out of luck pretty quickly. And, it's often hidden because it's not so much just the premiums, higher deductible. Co-insurance is the one that we see in our Bill of the Month project, kills so many people. They're like, wait, I thought I had a $25 copay. And I'm like, no. That's, as more and more has moved to the outpatient setting, people are getting hit with these, $12,000 co-insurance bills for procedures, and they can't pay. We know from a study or a series of articles that we've been doing, Levy's been doing for the last 2 years, that 100,000 Americans have medical debt, and
100 million.
100 million.
Yeah.
If only we're that 100 million have medical debt, and something like 20% of them never believe they'll be able to pay it off in their lifetime. And, you see these payment plans where, when I do Bill of the Month, we have this project called Bill of the Month with NPR and the Washington Post. And, people have these payment plans that just $200 a month sucked out of their income forever. And they'll never be able to pay back. So, as you said, it's not that the hospitals are really making off like bandits, because a lot of people can't pay that much. Boy, they really try and squeeze money out of people, putting liens on homes and, keeping Social Security checks.
Yeah.
It's really inhumane, and it's certainly not good medicine. So, and I think states are trying different things to intervene in this messy system. There's some are trying to offer a public option, which is kind of interesting. I mean, it is interesting because it says to the commercial insurers, it kind of throws down a gauntlet saying, if this isn't as good as the public option, people will walk with their feet. Then then you get into the debate of what should a public option look like? Will it look like Medicaid, Medicare, something in between? And it always gets stuck on how are we going to pay for that? Because the prices are so damn high that the providers are getting right now. So, and we're allergic to some kind of price setting or price capping. So here we are. Yes, I'm always hopeful and I love talking to groups like I think it used to be called the Pacific Healthcare. It's a buyers group or a bunch of companies. Now it's called, I think, the Employers Group on Health. They try and get together and negotiate with the big insurers on behalf of a whole bunch of mid-sized companies. I've yet to see it make the kind of impact I would like. They're certainly better and worse. My foundation, because it's into kind of radical transparency about healthcare. We see every year how much our healthcare plan costs, and it's getting on 40% of a salary now. Wouldn't people rather have reasonably priced healthcare and more money to spend? I mean, I wrote something for the Washington Post a few months ago saying, guys, forget about the price of gas and eggs. Look at your healthcare costs, man. That's what's really, I don't know how people do it. I really don't.
No, I agree. And how people do it and then not get results, and not knowing the price. I mean, what is the price in healthcare? If you bought something from Amazon and you found out 3 months after you bought it how much it was, and only after going through 3 or 4 intermediaries, I mean, that's how opaque it is. That's how much friction. And the denials, and I mean, we could go on and on, but where does it end? But I want to pick up on something you said a minute ago, and this is in line with what Don was saying about employers just not getting involved, giving it to HR, because CEOs think this is an HR problem. Because and I've developed a tool, and it's called the denominator audit. As a matter of fact, if you go to denominatoraudit.com, you can put in just a few simple numbers. What is your top line revenue? How many employees do you have? How much are you spending on healthcare? And instead of, talking about, I could save you 25% of your healthcare costs, and if healthcare costs are only 4% of the total revenue, it's only 1%. But if your after-tax profit, and most companies don't have after-tax profit that's in the double digits, as a percentage of that, it's a much different picture.
Yeah, for sure.
And I think that's where hopefully employers will say, we have to do something.
I think one little thing that I do have in our corner, and I wish more employers had this for now, until there's is, my foundation has a relationship with our primary insurer. And if things are not going right, there is a person in the HR office who knows a person to call at the insurer to try and make things right. I don't think most HR offices have that. I mean, that's necessary now. A kind of troubleshooter. I mean, I think what we get so often now in our bill of the months is, I had one of them I did myself was about a young woman who got a cochlear implant. The hospital, she had pre-authorization for it, but the insurer said the hospital coded it wrong, and the hospital said no, the insurer was wrong. And this poor young woman was like, why am I playing referee? She's setting up 3-way calls between, where she did everything right. And yet she's stuck with this huge bill that she knows in the end she's not going to have to pay, but she's very well educated. She has the kind of job where she can argue. And, she has kept proof of the pre-authorization. And she had an employer she worked for a state that said, guys, you guys decide. But, I mean, they often don't decide, and patients are left holding the bag. And this is what we've seen in one of the few little triumphs I point to of our work and my work is the No Surprises Act, right? But so when people got surprised out of network bills, they did, or in an emergency, they didn't have to pay. The insurer and the providers are supposed to work it out. That's kind of a great thing, but instead of saying we're just going to pick a number that they pay, or they only pay what they would pay in network, they end up with this nutty baseball style arbitration where, who wins in that? Not the patient, the providers do. And they get, now there are lawyers who do the baseball style arbitration for the providers. And so, there's yet a system that was a new law that was supposed to solve a problem, created new business opportunities and didn't solve the problem very well, or not fully. And I said, like, when I heard they were going to do baseball style arbitration, I was like, gee, that's great. They're like, what? I'm obviously not a sports fan, but 400 baseball players who are negotiating with, maybe it's 1,000 with 20 something teams. They're like, 7,000 dermatologists in, the suburbs of New York City. Like, you're not going to be able to negotiate each bill. I mean, that's nuts.
Right.
It was such a crazy idea, but it was all they could get through. It's just, I'm endlessly in awe of how incredibly quick this system is to see a new business opportunity and go after it, and how there's not a sector that's saying we're going to stand up for employers. They're not banding together. The unions get really good insurance, but everyone's out, for like what we can have for ourselves. You can get a good rate maybe for state employees, but what's going to happen probably? It means that the other people who are not working for the state end up paying more, so the state employees can have. So it's such an agile system in terms of its business practices. It's kind of awesome from a Harvard Business School point of view, I guess.
Right. Yeah. I remember, you know Reggie Hertzinger, right, at Harvard?
Yeah, sure.
Yeah. I used to, occasionally she'd invite me to talk to one of her classes, which I did way back. She's still active there, not as active, but it is a classic case for that. And the thing is, there are solutions. There are a lot of special interest groups that get in the way and try to prevent them, but it is fixable. It's just, it's frustrating because the right people aren't getting involved and they aren't saying enough. And, it's like any kind of change. Eventually the math is going to make the decision. If people don't get involved, and then we don't know what we'll have.
Yeah, I do think, but how do I say this? I thought 10 years ago we were at a tipping point. Now I think we're kind of over the edge and hoping to crawl back up because, it is very hard to see how you undo the insanity in this system. I mean, in a system of direct contracting, you don't really need like these armies of billers and coders and negotiators. So it's a jobs program, right? So, the hospitals will say to the mayor, well, we can't do that because we have all these people who we employ, and, forget about AI, direct contracting, will kind of obviate the need for, 20% of what we call the healthcare workforce. I mean, it really disturbs me when, we look at the jobs numbers each month and the one sector that's growing is healthcare, and everyone goes, oh, isn't that a good thing? I'm like, I don't think so. I mean, it's, if I thought it was really growing in quality care for older, adults, or homebound adults, or I would say great, but it's not. I don't think that's where it's growing. So
no, it's growing in complexity. I mean, if you look at remember that chart, David Himmelstein and Steffi Wolfine about the growth of administrators versus physicians.
Yeah.
I mean, that's what it is. It's the administrators. If you look at our healthcare spending, it's larger than the GDP of Germany. It's second only to the GDP of the US and or China. Germany is the third GDP in the world. our healthcare spending is larger than the third largest GDP. So, and we're certainly not the third largest country for population. So it has to change. We just can't keep going. One of the things that everybody's talking about is AI. Maybe AI is going to fix this. And the way I see it is, do you remember that film with Howard Beale, Network?
Yeah.
It's like, I feel like it's like putting a jet engine on top of a Ford Pinto with a full tank of gas and expecting some good results. You're just going to hit that pothole faster and it's going to implode. So AI on top of a broken system just means that black box is speeding down the highway quicker. And
I get endless emails in my inbox every morning from people who have a great AI for healthcare. And I'm like, a great use of AI. And people are making good money writing newsletters and courses about AI for healthcare. But what's the goal? It's greater efficiency, greater return on investment. You don't have to pay the salaries of, I was just corresponding with someone who was asking about AI scribes in healthcare, Yeah, it's good for doctors. It saves them time. Pity all those poor young people who took courses to become certified as medical scribes because they're out of the picture now. And I did a little experiment with my rheumatologist where he was kind of an early adopter. And, we looked at the AI generated notes and they were pretty good, but he had to go through them. If you're just thinking about efficiency, wow, it's way more efficient, but it also creates problems that had he not corrected them, they would have been carried on in perpetuity. And there was a very good op-ed in the New York Times Magazine just last week about that a physician, Helen Oyang, wrote about how using AI in medicine and what's lost when you do that.
Yes.
For care. More efficient, but that's, if your goal is profit, more efficient is the goal, more efficient so long as you don't get in trouble for really bad care, which we seem not to have. People ask me, how could they keep, I wrote an article for The Atlantic recently about my husband who died last year.
I was sorry to hear that.
Stuck in, thank you. He was boarding in the ER for 4 days in his last admission. And, people say, well, why do we let that happen? And I'm like, well, is there a CMS police force? No. We let it happen because there's no rule. There's nothing saying it can't happen.
Right.
And it saves hospitals money to count someone as an inpatient when they're in fact sitting in a hallway, even though it's inhumane. And it's terrible care. But, I would love it. You tell me, what do you think is the answer? How do you drive a wedge into something that is so powerful in this country and which people hate so much? I mean, I think that's the thing. People are waking up to the fact that, and this has changed in the last 10 years. We used to say, oh, well, they wait a long time in Canada for things, try and find an appointment with a new primary care doctor in New York. Or a neurologist, how's October for you? We wait endlessly. Now, if you think you might want a knee replacement, which is really profitable, you'll have it done tomorrow, whether you need it or not.
Exactly.
Right?
Yeah.
So I think it's, I always kind of joke that I'm just going to keep banging my head against the wall, writing and talking about this until something changes. I think employers have woken up and voters have woken up, but they don't know, they haven't been presented with what seems a simple alternative. And it's like, Donald Trump said, oh, who knew healthcare was so complicated? Most people, they sign up for a plan they hate and hope they never get sick, right? Knowing that they won't be able to pay the deductible if they do. And employers, they're just not made for this. So, yes, we can have a new form of intermediary to try and, do a Hail Mary around all this messy infrastructure. but there's going to be a lot of resistance from the messy infrastructure that's doing very well, thank you, from much resistance.
Yeah, exactly. So what I'm doing is I'm like, the work that I'm doing with AI is, as I said, if you strap it on top of a broken system, it's just going to accelerate the chaos and increase the confusion. But I've developed sort of a suite, the denominator audit, which I told you about, but also I've developed something called healthcaregenius.com, where it's not completely ready yet, but what it's going to do is allow, and the thing is, Libby, with millennials and Gen Z and people are more used to they want to know for themselves. They want to figure it out. So I've got a suite of tools where my insurance denied me. Why? You can feed it into the system and it'll tell you why. It'll tell you how to fight it. If you look at the Medicare Advantage stats, the number of denials, I forget the exact number, but 89% of those that were denied just never fought it.
Yeah,
only 11% did. And those that fought it, of those 11%, which represent, I think, 7.7 million people, of those, 80% of the denials were overturned. So the denials were false denials. They were just delays,
Yeah. And, the problem is, of course, and I think in the commercial market, I did a story where someone told me that something like 5% of denials are fought, and it's partly because it's so much trouble.
Yeah.
It's you don't know how to start. They're like, fill out this form and, it's the wrong code and blah, blah. It's just so complicated. And I think that kind of thing is helpful. And I always want, we the patients to stand up and say, no, that's wrong. But boy, it takes a lot of gumption and a lot of fight. And, and then when the billing office says, no, it's coded right, our bill of the month patients, I love them because they're like, they go to the CMS database and look up the correct coding initiative, and they go to their state attorney general, and they've fought with the hospital, and they've fought with their insurer, and they've, and they end up going to, like, we're like the police, I'm going to report you to bill of the month. And it's like, we can get it fixed often because you have a journalist calling the hospital and the insurer, and they're like, that isn't right, we'll fix it. But, it's a heavy lift. And I think more people challenging denials and knowing how to do it is a really important part of. And I think if you have an employer, that should be a function of HR offices. I mean, there should be a designated person who you don't have to fight your own, and this does actually work quite well at KFF, the Kaiser Family Foundation, because, we have a relationship with our insurer, and the foundation will move if someone in our office knows the right person, has a contact at our insurer, and can, you can say, here, look at this is wrong, and it's often taken care of. You'll often get a call in a day or two saying, you'll get the pre-auth code by Monday, but it's a messy process, and companies may not want to hire that person. An AI tool will help certainly people know when they're in the right, which is really valuable, and know like how to go about doing this otherwise impregnable thing. But I hope this works. I'm not sure collectively if there are enough people with the knowledge. And I mean, like you said, young people are very motivated to do this kind of thing and used to doing things with apps. But I think the other side of that we should be thinking about as a country is, there's a real, among young people, and I happen to have two of them, a real startup culture. My daughter has a company that's been quite successful. She can't hire people because she can't afford to give them health insurance, right? That would break the bank for her company, even though it's a successful. So, they work for his contractors and, they buy insurance on the New York State Exchange, which luckily is not a bad exchange. But, if we say we always talk about this, every president, we're a nation of entrepreneurs and small businesses. You can't be in this
No.
culture. You can't because of insurance, not because of anything else.
Right.
It's because of insurance. And that's, to me, like, as a society, something we should really worry about, because the ripple effects of our failure to have an affordable healthcare system on companies and on our future as a producer of new ideas, I think is really devastating.
Totally. Yep. So who really profits from the confusion? That's kind of my last question that I have for today.
I think in my book, someone said everyone's feeding at the trough, insurers, pharmaceutical manufacturers, PBMs, doctors, to a lesser extent, actually. They're getting more and more radicalized. Something that I didn't even anticipate when I wrote the book was private equity. I mean, private equity just bought the radiology practice I go to. And now, what was formerly pelvic and abdominal sono one thing is now a sono of your uterus and a sono of your left kidney and a sono of your right. It's, the billing is totally unbundled. They're out of network. I'm not going there anymore. But who's profiting off that? No one having anything to do with healthcare.
No, exactly.
So I think, should we, and then you get into the, I'm not anti-business, but should private equity really be having a role in healthcare? The studies have all shown that when private equity acquires a healthcare property, from whether it's a practice or a hospital or a facility, the quality of the care goes down and the prices go up. Why? But we don't have a way to say, no, we just have, there's no mechanism. And yes, the employers should bind together. And I think maybe it was before we were recording, we were talking about Chase and Berkshire Hathaway and Amazon trying to do this. And they have millions of employees all across the country. And they had Atul Gawande as their CEO or something. And they couldn't do it. So why didn't that work? I mean, I was hoping that would be a model for, kind of a yes, we can to businesses.
Right.
But I don't know. It was a big question mark to me. Why didn't that work? Are providers so powerful and insurers so powerful that, you essentially need a Medicare to have, or a state employees union to have any kind of market power?
Yeah, I think it could work. It's just the incentives. I don't think the incentives were adjusted enough. They just thought with, millions of lives we could negotiate better, but I think the incentives needed to be changed just a little bit. I think it's doable, Libby. I think it is.
I do too. I mean, it's not like this is, violating Einstein's law of physics. It's just that we don't have, there's too much money sloshing around that wants it not to happen. I mean, one thing that would help that, I know it's a favorite of all of us who think about healthcare. Why don't we have site neutral payments yet? Because,
well, like the state of Maryland, the all payers, that seemed to work pretty well.
That worked fine. Worked fine. I had a neurologic problem. I had what do you call it? A spinal tap at Hopkins, $1,000. They wanted like a second opinion. And it was in a doctor's office procedure room in the hospital outpatient department. I booked one at NYU and, there it's done in, a procedure suite by interventional radiology. I mean, for $22,000,
Wow.
So why don't we say, a spinal tap is a spinal tap, and you can do it wherever you want as long as it's safe, and we're only going to pay you that much.
Yeah,
but
exactly.
That seems like a total no-brainer, and yet who's going to say that?
Right.
A company doing direct contracting could.
Yep, exactly.
But a hospital would fight back. A hospital that had bought doctors' practices and surgery centers would fight back because they don't want the doctors doing that in their office anymore because they make much more money if they do it in the hospital.
Yeah, exactly.
So, I think the direct contracting is a hopeful thing. I see how to grow it into something powerful. Like I said, cost plus drugs has become something powerful for patients. So maybe this will too.
Yep. I hope so. We're building software to, make it to help it. So hopefully that'll work. So Olivia, if people want to follow you, find out a little bit more about what you're doing, how can they follow you and read you?
I'm on LinkedIn. I'm on Rosenthal. I'm Rosenthal Rosenthal Health on Twitter. I have not dived into Instagram or TikTok yet, but I have, I'm writing here and there. You can look at the KFF Health News website, and I have got a new book probably in the works. So,
great.
Kind of a follow-up.
I can't wait.
So, yeah, book publishing is my kids who are like, the Instagram generation are like, just put out everything on Instagram you want to say, or get a Substack. And, right now I KFF is my overlords, and they do the right thing about healthcare. But
yeah, I think they do.
It's very hard. Even when I was working at the Times, where I loved the place and had a great 22 years, it made me a little nuts to be doing these stories about the high overpriced drugs, and then there were pop-up ads from Pfizer, and I would be like, this is like it's so not the message.
I've lived in 5 countries on 3 continents. U.S. is the first place I've ever lived where pharmaceutical manufacturers can advertise to the public.
Oh yeah, well, it's only here in New Zealand, and and the ads, not only are they for pharmaceutical products, but they're for like niche drugs that they're orphan drugs. They're for like, an ad goes up and it says, "Do you have AMMDR heart failure?" And I'm like, I trained as a doctor. I have no idea what this is, and I look it up, and it's 1,000 people have it. So why are they advertising on the Super Bowl, and the World Cup? And it's because this drug costs, $500,000 a year. And if they get, 20 patients over or 10 patients over, that's all it takes. And, so it's a very corrupting system. But, whenever I say that to anyone, a colleague who works in television, they're like, don't write about drug advertising, like, because they would, the cable TV would be dead without drug advertising.
Well, I like to, as a former air traffic controller, I like to kind of come in and look at all the chaos at a high level. And I'm sure as an ER doc, you're the same. You have to jump right into the chaos, figure out everything that's going on, and get things organized. And I think that's the kind of mentality that you need to fix this. So everything you're doing, everything you write is fantastic. It's all building awareness. It's all shining a spotlight on the things that need to change. So let's stay in touch about things we see changing that might work, because hopefully they'll scale. And I think I'm always looking at things that are happening in small areas or in the States, because to me this might be something like gay marriage that once one state figures out how to do it and do it well, other people will say, we could do that too. So one company, so I think there are ways out of this, but it takes an air traffic controller to see them, I think. Anyway, I'll keep doing my work, and I better get on. Thanks, Libby. Great having you.
Thanks,
Talk to
Ralph.
you soon. Thank you. Bye.
Good to be in touch. Bye.